hopefully you've got some slides on the screen, is that right? Good, lovely. So I said I'm Matthew Rowcroft, consultant geriatrician at Rotherham, and we're going to cover the agitated patient. So firstly, kind of the biggest thing with agitation from a geriatrics point of view is delirium, but there's lots of other causes we'll look at as well, but obviously a big part of this is around delirium. Then looking at kind of history, examination, and moving on to your cases. I'm very much going to cover kind of what I do. That is slightly different, I think, to what I would expect someone to do who's only looking after the patient for a shorter period of time. Certainly in an overnight setting, as I think there's less absolute requirement to get a diagnosis 100% right, but you still do need to manage the agitation as you would at any point in time, really. So there are subtle differences between them, but I think it's worth covering just what I would do, which should probably a tiny bit more thorough, because it needs to be, because I need a diagnosis because I've got that patient for days and days and days. So there might be differences there just to think about. So delirium. I think this is a really nice description of delirium, and it's from something called the Silver Book of Geriatric Syndromes. I'll just let you read it for a second. I couldn't help myself with this, but add that last figure, not just the diagnosis. I think it's just really interesting. And if ED kind of miss that percentage of cases, well, I'm sure we're no better in medicine. I don't think that's a criticism of them. I just think we miss delirium a lot. That's why delirium screening is such an important thing, really. And even with screening, I don't think we're wonderful. So delirium's complicated and common, especially in older patients. And I think when I think with delirium, you need to understand the slight difference between delirium, dementia, less so depression. But I think this is quite a nice example of the difference. The dementia being the kind of insidious, it has progressed over months to years. The delirium being much more acute, fluctuating, better or worse, a consciousness that varies with delirium. It can vary up, which is the agitation, or it can vary down, which is the kind of negative delirium, the drowsiness. And interestingly, the down is often slightly has a worse prognosis, although it's in some ways easier, certainly from your perspective, because there's not as much you need to do out of hours. But it can be harder because of all the consequences of not doing anything, not moving, not eating and drinking that come with a negative delirium. So that's the kind of key points kind of there on the screen. Delirium usually reverses, but there's a significant amount of patients with a delirium, maybe a third or so, that go on to have some residual cognitive deficit from that. So that's delirium, dementia, and depression. So causes of delirium or agitation, really. From a geriatrics perspective, you can't really talk about anything geriatrics without saying kind of multifactorial. It's lots of little bits of things. It's a brain that's a bit old and a bit prone to kind of things going wrong. It's maybe a slight electrolyte problem, a slight issue with pain, and a little bit of an infection. One of those on its own probably wouldn't do it, but when you start combining lots of things, you start getting kind of agitation and delirium. One of the simple ways of looking at things, well, I've got to say I don't use it myself, is the pinch mean mnemonic, which I've got on the right-hand side, and I've got on a number of screens. I think that's really worth certainly people that are less used to managing it looking at, because it covers the kind of main key areas. Although I think the main bit it does miss is urine retention, which is relatively common in men, much less so in women. And then the other bit to look at is always intracranial stuff, but I don't think people miss the intracranial stuff very much. They certainly do miss urine retention. And if I quickly run through the things on the right-hand side, pain is often obvious but not addressed. It's why you get post-op delirium in lots of things. Infection is often you can work out what it is, not always where it's coming from, but that it's there. Nutrition is very complex. Constipation is missed all the time, as is hydration. They need really, really accurate nursing notes, which certainly I don't think we have all the time in Rotherham because we don't have this kind of charts. I much preferred it back when we had paper charts for picking up these kind of things. Medications is complicated, and there's a whole list of medications that can cause agitation and delirium in patients. And finally, environment, and a lot of that's about that kind of altered environment, but also what you can do to settle things. There's also the non-geriatric causes, which I expect you'll see a lot of. Alcohol withdrawal's got to be right up there with it, being quite common. We see that in our elderly population as well, but that's agitation in younger patients very commonly. And drugs as well. There's a whole list of drugs that cause it. But I think this is becoming an increasing problem with the kind of newer synthetic drugs. The number of people presenting who are just appearing crazy with having taken spice or something like that is becoming an increasing problem. I think it wasn't something that I saw back 10 years or so ago. They just didn't have that same kind of difficulty in managing them. And finally, psychiatric. I'm not going to really cover the psychiatric cause of things in detail, although the initial management is generally very, very similar. So I think that's something that you should always be thinking about. Is there an obvious cause for why someone's gone like this? Not just they're agitated, what do I do about their agitation? It's the why are they agitated? And I kind of think the main things to think about there are alcohol, plus or minus drugs, and that pinch me list on the right hand side. But as it says at the bottom, you can't always find a cause. Even if you're really, really thorough, you look at everything again, you still can't find a cause. Sometimes it just seems to be there. I'm going to skip that out because I think it'll be easier to engage with people later. So I'll move on to the history side of things. And I don't think there's anything complicated here. This is things that certainly when I read reviews by staff working out of hours, I think this is covered wonderfully by you. And I think the examination is as well, actually. And it's a simple history of presenting complaint, but specifically the systems inquiry side of things. There's not a huge amount in medicine. I go through lots of systems for looking for kind of random stuff that isn't obvious. Most people who are younger kind of present to you and say, this is what's wrong. So you just look at that one system. Whereas agitation, delirium does kind of necessitate that systems inquiry because anything that's broken can cause it. And by definition, them being agitated means they don't tell you things. But there are specific areas to it. And that's some of the ones I've covered already. So the alcohol, bladder, bowels, intake. And then finally, drug history. And the bit to add to drug history is recent changes. What has been added recently? Did a GP start something a few days ago? Has someone started something in the hospital? Has someone stopped something in the hospital as well? Because that's a very common side to things. I'd be much less fussed about a drug history being done out of hours, but I do think kind of systems inquiry looking for pretty much everything is not that time consuming and incredibly useful, whereas a drug history can be very complex and time consuming and trying to work out exactly what's happened when. Examination, obviously as directed by the history. And then there's kind of two ways of looking at it, I think, either by system, just going through, we'll look at respiratory, we'll look at various different things, or by looking at the various different causes, again, going through that pinch me side of things that I've left up, or any other kind of way you have of looking at things, really. But whatever you do, the examination is relatively thorough compared to examining for a lot of things, I think. So I thought it was useful to cover kind of what I do, because I don't take huge lengths of time doing things, but there are some things that I think I look at pretty much every time, and that's what I've listed here. And I don't think this is that complicated. So kind of feeling abdomen, looking for specific pain, making sure there's nothing funny going on with the bowels, specifically making sure I can't feel a bladder. And then kind of very basic neurology. I don't think a full, thorough, detailed neurology examination is that helpful with delirium, but I do think making sure there's nothing obvious going on. Specifically kind of looking for tremors, particularly for alcohol withdrawal, and just making sure arms and legs are moving okay. And there's nothing obvious. It's more a screening test, I think, than anything else. Looking for head injuries, really quick and simple. Respiratory, I do simply by just watching breathing in the vast majority of my patients with everything nowadays. But particularly here, I think you can see if there's something very wrong with the breathing, and you've already got SATS probes as well to pick up something like that. I don't trust respiratory rate on a chart. It's just often missing things. You can see a lot more by looking at someone going, your breathing's normal or your breathing's not normal. And the bit that I add in that I think a number of geriatricians do, but not many people from other specialties, is looking at legs for infection. Probably because a lot of patients who have cellulitis don't seem to tell us they have cellulitis. That's certainly because of the age of our patients, and often they have other things going on as well. They're just not as aware, especially if they've got underlying cognitive problems and they get delirium on top of dementia or something like that. So quite a quick examination, really. It's not going into anything in a kind of perfect way that you might be have taught to do them for when you've had examinations and things like that in the past, but just kind of quick. Feel the abdomen, make sure there's no tremor, move legs and arms quickly, check there's nothing obvious on the head. Does the breathing look normal? Do the legs look normal? It probably takes about a minute. More than that is very unlikely to pick up very much, I think. But you could argue that there's other causes that I'm not specifically looking at, but that's a general screening exam, I think. Investigations, obviously the kind of as directed side of things, but you're going through the kind of causes of it, looking for things. So obviously infection. LFTs are the one thing I think that gets left out of blood tests regularly, because biliary sepsis is missed, I think, quite often, and doesn't present with the kind of classic upper right abdominal pain that it's meant to in a number of people. So I think kind of LFTs are essential on bloods. More complex bloods than this, I'm really not that convinced about. You hear about confusion screen on bloods, things like thyroid, calcium, and things like that. That's really a dementia screen. And I think there's less definite need to do it in these patients. If you're thinking dementia, yes, that needs doing at some point. But I'm less fussed about it in a kind of acute delirium. Something has acutely changed, whereas thyroid problems are long-term problems, B12 deficiencies are long-term problems. Calcium being high takes a long time to present and doesn't just suddenly come on one day. It has a history of just gradual change in things. Imaging's complicated. I don't routinely do chest x-rays, but a lot of people do. Head CT, there's complex criteria generally for head CTs, but it's essential really if there's trauma or they're on an anticoagulant, or you find any neurology. Beyond that, it depends what else you're finding, to be honest. I kind of think if I can find something that's causing it and they've got an obvious infection, their CRP shot up to 150, well, I've got a cause. I'm not that fussed. If they haven't, I'm much more likely to get a head CT just to make sure there's nothing there. Although I have to say its pickup rate is very, very low from personal experience. And if I've got something very obvious and they're on an anticoagulant, I probably wouldn't image them either all the time, unless something was unusual. I don't quite know what I mean by unusual. Sometimes things are just down to experience and going, this isn't behaving right. But so I wouldn't always do it in people when there's an obvious other cause as well. Urine, please culture, don't dipstick it, just send it off. Dipsticks are useless for all elderly patients and most younger patients. And even if the culture shows something, it doesn't always mean there's a urine infection. But it's often kind of useful to at least have something there. So if you're giving antibiotics at some point, you've got something to guide it off. And recently, I COVID test everyone with confusion. COVID was the presentation of COVID in elderly. Delirium is right up there as amongst the most common causes. Certainly, you get as much delirium as you do kind of any breathing distress with it. So that's just kind of become part of routinely what I do. I don't look at any other weird viruses or anything like that. So management plans, and this is more onto the not just delirium, but very much onto the agitation side of things. And the bit at the top of this is the most important thing to agitation. And I think it's very hard to teach. It's certainly impossible to teach properly in a setting like this, and it's something I think needs to be demonstrated to a degree. But conservative measures, thinking about environment, thinking about space. One of the things that I very, very commonly see with agitated patients, by the time I get called to them, there's 5 people standing around them. They're not allowed to move more than 30 centimeters till someone's in their face, because the patient has moved into someone else's space, but the patient doesn't see it like that. They see someone else being very close to them. So giving people space to not feel threatened by you, and remember their thought processes aren't normal at this point, so they're much more easily threatened than if they weren't confused and agitated. And then looking at the kind of basic needs, that's food, drink, ideally things like clocks on the wall so they can see what time it is, decent kind of changes in lighting from day to night time and things like that. But particularly kind of a non-threatening environment, I think, is probably the most important bit with this, because a huge amount of agitation can be managed conservatively by people giving someone time, by withdrawing the perceived threat. We know it's not a threat, they don't know it's not a threat. And just stepping back, and body language that is very definitely neutral, something that's leaning away from the patient, certainly not something that's leaning into them. Again, thinking about their perception of how you're standing. I quite often sit myself 2 or 3 meters away from them, because it's a posture that's obviously non-threatening, really. You're not standing up and they're not interpreting. There's no way someone interprets someone sitting away from them as threatening. That's not an absolute. There are times when I wouldn't do that, when I think you're just not settling and I need to be able to move. But that's generally something I find myself doing quite often. The management plan, addressing history examination tests. I don't really need to tell you about that side of things. I think you'll know that side of things already. The bits I specifically add, and the earlier it gets added in, the more useful it is. So it'd be really helpful if you could think about these things, is just initiating kind of bowel and nutrition charts. Bowel charts 100% of the time, nutrition charts if there's a concern about nutrition. I've spoken already about medication. I would look at it in all of these people. But as I say, it's time consuming, and I don't think it's necessarily something that I would expect people to do who are just seeing them for a few hours. And finally, sedation, which is an incredibly complex topic in itself. I don't like sedation. I hope you don't like sedation. It's medication with significant side effects. But it does work, and there are times when it's needed. And those times when it's needed are when the conservative measures are failing and the patient remains a threat to themselves or to others. So if you're giving the patient room and they're coming at you, yes, their patient has become a threat to you. The risk benefits of giving them something completely changes. Or a patient that you think is just going to hurt themselves somehow by what they're doing. Although that's often a double-edged sword, sedation leaves people drowsy. Alcohol withdrawal, benzos to treat it, and whichever benzo you want to give, be that chlordiazepoxide or lorazepam or whatever your local protocol says, they are to a degree sedation, but they don't work in the kind of benzo way that people who are benzo naive generally have them work, because they get downregulation of their GABA receptors. So they need a lot more of these drugs, and the management of alcohol withdrawal is benzos and more benzos and more benzos until you start finding that they're getting drowsy or that you're just not getting anywhere with it. And then a lot of the time they seem to then suddenly crash, and then get very, very sleepy, and they sleep for about a day, which is something about the way that benzos are kind of stored by the body and their kind of fat solubility. But more benzos is generally good whilst they're wired, and they can be given very, very regularly. At what point do I think someone should be getting a medical registrar or consultant to see them? Probably when they start getting uncomfortable. I think that's kind of a personal experience decision. I'd expect anyone to give a dose or two of benzos to alcohol withdrawal, probably 3 or 4, beyond that, I think is very much a personal experience and what you're used to doing and how used you are to giving drugs to these people. And so I don't really have an answer to that one of when to get help, but it's when you start thinking, if I give you more, you could well get sleepy. What do I do? Side of things. And a lot of the non-delirium patients, there is always the risk somewhere along the line of critical care being needed, which is fine. Sometimes it is needed to help manage it. Certainly with the kind of, as I said earlier, the synthetic drugs, and alcohol, not infrequently. Choice of sedation, you have two main drugs, your benzos and haloperidol. Both work. I don't have a huge preference, to be honest. I kind of prefer benzos in a lot of cases because they're simpler and their side effect is sleepiness. Whereas haloperidol starts messing with your QT interval if you're giving large doses of it. Occasionally someone gives it by mistake to someone with Parkinson's and it's a bit messy. So I generally start with benzos, but that's only really a personal preference. And if you're giving haloperidol, 0.5 milligrams is doing nothing. So if you're giving it, you need higher doses than that. Maybe something like 1.5 milligrams to start with. And ideally an ECG, but you're going to get an ECG on these patients? Probably not. So you can look back to previous ones to make sure there's nothing funny with a QTC there. Which is why benzos are just generally easier. You don't need anything funny. You just need someone to watch them and make sure they don't get sleepy afterwards. And if they're elderly and you're giving benzos, probably someone to sit with them to make sure if they get sleepy and then they kind of are groggy rather than asleep, when they get up, their falls risk is sky high. And that's that's one of the dangers with this. So you're managing not just the delirium, but the consequences of what's happening. So you've got the kind of double-edged sword of they're agitated, they're confused, they're possibly violent, and then you give them medication that makes them settles that side of things but causes directly problems in and of itself. So your documentation kind of needs to explain why you're giving this drug. There's nothing wrong with giving these drugs at all, and there's times when it's needed, as long as it's not first line, and as long as there's a risk to somebody, and that can be staff. There is nothing wrong with giving someone who is wielding something or coming at people something to stop them doing it. But generally, I think you need to have that risk before going down that side of things. I'm sure there's a few exceptions to it. I just can't think of them off the top of my head. So if you have, maybe we'll talk about those in a minute. So that's it, really. From here, I was just going to move on to your cases, I think. And I'm going to come off slides and hopefully get my video working on mobile, if that's all right. So, Helen, I know you had some cases. Yeah. So I'll stop sharing my screen.
Okay.
And hopefully my mobile's working, so you can see me now. Helen.
Yeah. Can you guys see that?
Yep.
Yeah.
Cool. Okay. Yeah. So I wanted to discuss this case, and I'd be really interested for everybody's views in it, and especially yours, Matt, because I found it quite an uncomfortable situation that I found myself in, with a lot of pressure from the nurses to sedate a patient, where I didn't particularly think that any sedation was indicated. I agree, I don't like sedating patients. I don't like sedating elderly patients. It's usually like my last course of action. So yeah, this was quite a tricky situation for me. And yeah, I'm still sort of searching for answers, I guess. So overnight, I was asked to see a patient who was allegedly attacking another patient. I understand that this gentleman was 75 years old. He'd been in hospital for quite some time. I think he'd been repatriated from Sheffield from their neurology unit. He was a gentleman who had collapsed at home. He was found in quite a poor state, really. There wasn't much food in the house, etc. And again, multifactorial falls was a working diagnosis alongside a poorly controlled diabetes, some social issues ongoing. His CT head did show that he did have a lesion there, and the differential was very much a meningioma with a hemorrhage. At the time when I saw him, this chap was clinically quite stable and awaiting placement in nursing or rehabilitation. So I attended quite soon after the call was put through, and I expected a picture much like what Matthew described, where you've got about 5 or 6 people around a bed, and what I found actually was a chap very much like what you can see in the picture at the bottom of this slide. He looked terrified. He didn't look like he was posing a threat to himself or anybody else. But this was from the end of the bay. So it brought me a bit of time, I guess, to speak to the nurses and try and get a bit more of to understand the context of what had been happening. This gentleman, I understand from the nursing staff, he'd had a fall a couple of days beforehand. His falls were increasing, as were his periods of confusion and frequency of threatening behaviour. On further discussion, I found that the patient hadn't actually physically harmed or attacked anybody per se. It was just that he had made threats of this behaviour and had sort of been within the vicinity of another patient's bed space when making those threats. But my sort of overall observation, the thing that stood out for me was this was an incredibly noisy environment for the time of night. There was lots of lights on. It was the stroke unit, and yeah, obviously predominantly elderly people on there. So it was a very busy unit that night. I think there was lots of nursing, staffing problems. But the main basis of communication from the staff was that they were insisting that this patient was sedated. They were concerned about their own well-being and that of the other patients. So it was quite a stressful situation, I guess, initially. Just as a bit of just to give a bit of context, this gentleman, he had very limited past medical history, as you can read, and nothing that really stood out to me on his medications. Having said that, he'd not been taking any of his medications for a number of days through fear of being poisoned, I understand. So my examination was very limited, and I didn't want to go and disturb a chap who did seem like he'd, for whatever reason, his agitation or threatening behaviour had actually been de-escalated, because he did seem quite settled. However, I did want to assess his capacity if I should need to give him some sedation at some point. So my examination very much left me feeling that the patient was very willing and amenable when I saw him. He was very, very willing to come and have a chat with me in the sitting room as opposed to where he was sat. He was quite confused, but he was convinced he was in the factory. He was convinced he was among co-workers, but he was able to tell me that it was pain-free and that he'd been eating and drinking okay. He was very scared, and he was very scared of a particular member of staff or a colleague, as he was describing the situation. So it was a strange situation, because he could almost rationalise these threats that he admitted to making. So he felt that if he made threats or if he hurt somebody else, that he would be arrested and moved from this place that he found threatening. So yeah, essentially, this chap did lack capacity. He was unable to retain any information that I gave him or make sense of a lot of the information I gave him. Having said that, he was really quite cooperative when I tried to measure his baseline observations, his blood sugar, and they were all stable, as were his bloods from the last few days. He did, however, refuse any further bloods taken. So there was no sort of gross weakness or gait deficit that I observed when watching him. And yeah, was happy to accept a cup of coffee and a biscuit as I put him back to bed. So it was a very different picture to what was painted in quite a panicked way over the phone to me. So my management was very much like we've just been listening to the pinch me side of things. I felt that because what I was seeing didn't fit with what the nurses reported, it possibly had a fluctuating course, and the likelihood of this being a delirium was quite high on my differential list. So I was very reassuring towards the patient. I involved his son on the telephone, who was really good in helping me orientate the gentleman and reassuring him, you know, he was safe. It was difficult, I guess, to test the hypotheses of a lot of the pinch me things during the middle of the night, the lack of nursing notes in terms of hydration and nutrition. I knew this chap could possibly be constipated, but again, not taking medication. So there was a few possible causes for this possible delirium, I felt. The ward staff had, I believe, made a bit of a knee-jerk referral to the mental health team even before I arrived on the ward, and the crisis team actually attended in the middle of the night, which was wonderful. It's not the sort of thing I've been used to seeing when I worked at Sheffield, but yeah, I guess it was an unusual and complex situation for me, so I valued their input. They were under the impression that this gentleman should be sedated and put in a cubicle. So I thanked them for their input and took advice in terms of referring him on in daylight hours to the elderly mental health team, who would possibly be able to give more of a specialist view on the state of play for this chap. I did a lot of, I guess, reassurance and educating with the staff on the ward, and really tried to stress with them that they should have a low threshold to re-escalate this chap to us again and the security team. Because of the complexity, I guess, the situation, and the fact that I had not seen any threatening behaviour with the chap, I didn't feel that there was really any indication to sedate him at this point. However, the patient had made verbal threats towards other patients. So it was a really difficult one ethically for where I stood. And I guess I still don't really know the answer, which is why I'd be keen to hear what other people would have done in the same situation. But the medical registrar, who I discussed this with at the time, was very insistent that he should be given some sedation. I did explain the multifactorial elements of this chap in terms of his very high falls risk, that he did have a meningioma that had been diagnosed on head CT, and I guess most strongly really my feeling that I did not feel that there was any indication here. So I reluctantly prescribed a one-off dose of oral lorazepam, but which was PRN, just to be used if there was any further episodes of agitation. So yeah, this sort of left me at a bit of a crossroads, really. I felt quite uneasy with the position I'd been put in. I felt that there was potentially a few things that could be going off for this gentleman. Initially, like I've said before, possibly a hyperactive delirium with a fluctuating course, potentially progression of a meningioma. It's not something that I have dealt with before as an ACP, so I wasn't sure of how that might present. I was mindful of the fact that this chap had fallen 2 days ago, and he wasn't able to have a CT head scan, and whether that had any implications for how he was behaving now. And as well, did he have an electrolyte imbalance, which I also wasn't able to measure. So I felt like I've just said, just to summarise, you know, there was reported threats of threatening behaviour. It was a credible threat, I guess, to other patients and staff that had been witnessed by other staff. But there was a huge falls risk to him, alongside the vast array of side effects from sedating elderly patients and delirious patients. I didn't know whether this gentleman potentially had some underlying dementia, thinking back to his social history and his, I guess, acopia at home, and the possibility of giving him something that would escalate a neuroleptic sensitivity in terms of haloperidol in a, I guess, a Lewy body type of dementia picture. And the bottom line was he wasn't aggressive currently, and was actually an indication. So it left a bit of an ethical dilemma for me. So I guess without having any really specific resolve or advice, I felt that the learning points for me today have just been that I would continue to avoid pharmacological intervention wherever possible. And I guess the first line would be looking at those environmental factors, which were obviously hindering this chap. And I found, since I've been sort of preparing for this case-based discussion, that there's a much debate in the literature surrounding which would be the first line, I guess, types of sedation to use in these types of patients, especially when delirium's present. Much of literature does talk about ITU dementia and post-op dementia. From what I've seen, so I don't know if anybody's got anything else that they could share which might be helpful. And yeah, I think stripping it back to basics would be that I guess our primary management goals are to create a safe environment for these patients and to ensure that it's an environment which we can sort of facilitate an adequate assessment and treatment in. I think it was good for me to sort of revisit delirium and really understand the comorbidities and the increased risk of death with patients who have delirium, particularly if left untreated. And yeah, that was my case really. And yeah, I'd be open to your thoughts really and opinions.
Lovely, thank you, Helen. I just wonder what other people's opinion is. Do you mind putting in the chat kind of sedate or not sedate? Kind of what your instinct is. Or just question mark if you've got no idea which way you'd go. I kind of wonder where other people would go with this. Or not.
I can't find the chat function, sorry. I'm having a technical error. I'll just add that I think putting a PRN dose sounds reasonable. Were you worried that they were going to use it and like not unjustified, but like do you think they would have gone straight to it because you prescribed it rather than waited for this kind of behaviour that they were sort of explaining before?
Yeah, very much so. I guess because I didn't know these staff very well. I of course was trying to balance taking their concerns seriously and trying to prevent harm to other people, but I felt that the risk benefit would pose more of a threat to the patient at the time. I guess I was feeling a little bit vulnerable after being told by a senior clinician that he was quite adamant that this chap needed sedating as well. So that kind of threw me into a bit of a tailspin really. And I was very insistent with the staff that they should absolutely not give this sedation unless the patient was a threat to themselves or somebody else, and that I would expect a phone call via fast bleep system if they felt that this was necessary.
Claire, you wanted to say something?
It's Carmilla actually. I just wanted to ask you, Helen, how you felt about having more of a discussion with the MedReg if you felt like you were reluctant to prescribe, just how you felt in that situation. And because I feel like for me, if I really didn't want to do it, I'd be like, but what if we don't do that? Like, how did you feel in that situation?
Yeah, like I say, it left me feeling very incredibly uncomfortable. And, you know, I guess working with me for many years, Carmela, you know, that I'm not sort of scared to say that I wasn't comfortable with the situation, but I did revisit this conversation several times with the person who was on call that day. And yeah, I was advised that I was wasting their time, actually.
Yeah.
Which I felt a little bit, I guess, a bit unsupported. It made me kind of look at my own practice and wonder whether I was. But yeah, in all the years that I've been doing this job, I've never been told that. So it was a bit of a surprise to hear. But like I say, I'm still without an answer, really.
Yeah, I understand.
I think that's
it's hard, isn't it?
Awful reaction you've got there, to be honest.
Sorry, say that again.
I think it's a pretty awful reaction you've got from them there, telling you you're wasting their time. Someone else was saying something there.
Sorry, that was just me, like, agreeing, basically. Yeah, not a great response to like a good discussion that you could have had, and what sounds like a very sensible one. It's just not necessarily the kind of support you need in that critical situation, really, in my opinion, anyway.
Yeah. Definitely. How to address that is a very complex discussion, and I think probably not for now. There's some very interesting comments in the text, and pretty much universally people kind of agree with the don't sedate or be very reluctant to sedate approach, I think. There's some interesting points, I think, though. I think Rachel brings up the point, the advice of the medical registrar and the mental health team makes it very difficult. I think that's completely true. I think that's a strange response from the mental health team, actually, which is, it's certainly unusual, but they're specialists in this. They're allowed to do strange things occasionally. Laura's put about using a small dose of olanzapine in neuro ITU. And interestingly, if this was my patient on the ward, I might be using risperidone, which is very, very similar. Because it just does a little bit of stuff in the background. It doesn't, you're not giving it to whack them out like you do with kind of proper violent things. You're just giving a little bit to help calm things. Nothing works wonderfully for a little bit of blood on the brain. It's just an irritant and your brain's just not right. But yeah, I may well do something along those lines, but I don't think that's something that you should be starting at all out of hours, actually. I think that's very much should be a consultant or specialist-led thing. So yes, they might use that in neuro ITU for similar patients, and yes, I might actually agree with it, but I don't think that's the way you should go with it in this setting at this point in time. Yeah, I think it's very complex what you're saying about the senior decision, and in the end, I spent years working with people who do things in slightly different ways to the way that I might want to do them. And the bit that I kind of come down to in the end is the decision wrong that they're making? Not is it what I would do, because often people do things in different ways, and certainly you see older patients managed by an acute physician and a geriatrician. The approach is different. We do different things. In fact, you see a patient managed by two consultants in the specialty, they do different things. And then maybe that's part of what we're looking at here. It's not that one approach is right or wrong, it's just that someone is suggesting doing something. You've gone to someone senior for an opinion on it because you're not quite sure and you wanted to talk to them. Is what they've said fundamentally wrong? And I don't think it is. And I think you probably don't think it is from the way you've kind of phrased it. You may not be what you wanted to do. It's not the answer you wanted. But if you're certain in what you're doing, you firstly wouldn't have asked them. And it's not wrong. It's not necessarily what I would do. I think your description is exactly kind of where I would have gone with it as well. I think, yeah, anything you want to say about that at all?
I guess I was thinking, I felt quite confident in how I wanted to manage the patient initially. I was getting quite a lot of conflict from the nurses on the wards, which made it more of a stressful situation than I guess than it needed to be. I did think there was potentially an element of the nurse being problematic, and I did sort of suggest that in a more of a diplomatic way, and we swapped the nursing staff around to see if that helped things, and it did seem to, because I did pop back on a few times. But I guess my concern, I guess selfishly and for the other patients in the ward, was what if something did happen, and I'd been advised from two more senior, I guess, and specialist people within my remit as an advanced clinical practitioner. Where would I have stood, I guess, and how would I have been judged on that decision, going against senior advice? So that was the predicament that I was concerned about.
And you end up without much choice, I think, in the matter. It's not a decision that is fundamentally wrong that they've made. It might not be what you wanted to do, and you may well have been talking to them because sometimes you just have to, because of a situation, not because if it was on your own, if it was just that patient without the pressure from the outside, you may not have spoken to them. But when someone keeps raising something again, at some point you do have to just ask someone else. And once you've done that, you are kind of stuck with the decision, unless it's wrong. Yeah, I think it's a very interesting point made by Donna about problems with staffing manpower, which is a huge difficulty with these patients. You can get one-to-one for like an hour whilst they're violent, and then it disappears, and then it happens again 3 hours later, because the ups and downs naturally do that. That's a huge thing. And the other thing is nursing staffing, training around this on the ward is absolutely horrific. It's better when it occurs in specialist units, but even generally specialist units like a geriatric ward, which gets this all the time, their nurses generally aren't trained very well in simple kind of de-escalation techniques, because nursing training on a ward is pretty horrific, I think, actually, and they don't get to go on the courses that they really should, because this is kind of basic. One of the most interesting experiences I've ever had was a few days working on the, I think it's G2, which is the older person's mental health unit in Sheffield. So it's not in the hospital, it's out to the north of the city. And they get the worst mental health cases that anyone gets, because it's a specialist centre. And they have crazy staffing ratios. They have loads and loads and loads of specialist nurses. And they're not quite one-to-one, but they're bloody good ratios, maybe 2 or 3 to 1. And they give very, very little in the way of drugs. That's because they are properly trained in de-escalation, and they have the time to have relationships, and they have those relationships longer term with their patients. So when it's done properly, it's very, very good. But many people don't know how to do it, so they do intuitively what they want to do, which some people are great at and some are not. And then there's not enough people. Even if they're great at it, they get called away to do something else, and then someone else, and there's just too much variability in the system. So there is all that kind of mess, and you can do it wonderfully for the 10 minutes that you're there, or half an hour or whatever, and then what happens? Yeah, really complicated. Thank you, Helen. Anything else you want to ask about or talk about with that? Otherwise, I think Donna possibly wanted to discuss a case.
That's great. Thanks for all your input. I appreciate it.
Donna, you sent me a message earlier with a case you were interested in. No. In which case, has anyone else got anything they want to discuss? If not, I might just run through the kind of done scenario anyway that she sent me, if that's all right.
I think Donna's not the most tech savvy, so she might be just trying to get a microphone on. But we were discussing the case on email earlier. I was one of the nurses present on the scenario that Donna highlighted.
Oh, lovely. So if you want to discuss it to people.
If you could just, if you just run through the scenario she sent you, then I'm sure she'll be happy with that.
One of them, elderly patient with urosepsis, and another one with dementia on a bit of lorazepam and agitated for the day. Which one do you think it was that we should do?
I think the latter, because basically we'd seen this patient. They were quite very agitated. I'd arrived first. There was another TACP in attendance. Then Donna had to attend. There were staff there. This patient had got so agitated before we got there that there was then basically feces everywhere, including our TACP. We sent her home early because she had to get changed. We stayed with this man for a good nearly, I think, hour and a half. Well, I did. And then let me just go on to her email at the same time, what she sent earlier for the timeline. Basically, I think the comment that she wanted to cover was the staff, it was on lorazepam BD and the staff had admitted it. Then we'd given something to calm him at that time. And I think it was about 5 in the morning. Then the staff had come on and caught his meds up and given some in the morning as well. By the time the doctors had come on ward round, he was obviously sleepy, and they'd commented in the notes that we'd over-sedated him as a team, which I think then we just found that obviously we can't predict what the nurses were going to do in future. We perhaps should have, well, we did discuss it with the nurse on duty, but it obviously didn't get handed over. At that time, it definitely needed not the sedation extra as a PRN, but sedation that had been missed throughout the day, which had, I think, then resulted in the scenario that we was in. And then I think because they've tried to catch their regular meds up, and given him the morning dose as well, it kind of, it was sleepy on ward round. I think that's the gist of it, really. But I'm sure if she could get a microphone on, she could explain it better than me.
No, that's basically along the lines of what I was sent. And it's quite complicated. And I think there's something about the kind of team in the morning kind of seeing them and stating that the patient was, quote, over-sedated. And I imagine that was quite hard to read when you saw that, I presume the day later or whenever you looked at the case later as well.
Yeah, it was awful, actually.
And it's probably something about that we probably need to kind of all remember about when we're seeing a patient. It's been time since somebody else saw them and the situation has changed. And the way it can be interpreted is different from the way it's meant. And the patient probably was literally drowsy because of the Medicaid, because of the kind of combination of things. Although I have to say, 500 micrograms of haloperidol doesn't make you that drowsy.
No, that's what we gave him.
It might just be a negative delirium, which was part of what was going on in the first place, or something like that. And then they're seeing them, and you gave it because you had to give it. And I think it's entirely reasonable, as I said earlier, and yeah, I think Helen said as well, kind of haloperidol or lorazepam. It's complicated. I don't think one's necessarily better than the other. You've made a choice, you've gone with it. I don't really think it matters too much which one you went with. And then you've got that complexity of the extra drug then being given in the morning as well. Goodness knows why it was missed. That was probably a lot of the trouble to start with. But you treat these patients, and if you're giving them something that's going to have enough effect, there's a decent risk you are going to sedate them. And that's kind of what happens, to be honest. I don't really see it as a huge problem. They get a little bit sleepy and they sleep a little bit. If you're giving them doses to calm them enough. Or maybe they've just been up all bloody night with it. and they're just sleeping
exhausted by the
because they
morning.
get to sleep, and you've just given them something just to help do a little bit more. So actually, if you really tried to wake them in the way that kind of, whenever you get an intensivist and you said that GCS is 4, an intensivist comes and says, no, it's definitely 9, because they're so aggressive at it. Maybe if you did that, you'd find that they actually did wake up a little bit. So I'd kind of not, I don't think I'd be worried about this at all. You've given a drug that you know this is what it does. You've got a good reason for giving it. You haven't given crazy doses. You've not jumped in at 5 or 10 milligrams of haloperidol.
No.
You've given actually a tiny dose, and I'm not convinced that's done this at all. And even if it has, well, actually, you gave it for a very good reason. You assessed the reasons behind it. You knew that these drugs do that, and you still gave it because they needed it, and it was the right thing to do at the time. So you made the right decision, and you just had a side effect or a consequence, or actually, it's just happened because it was going to happen anyway.
Yeah, personally, from this, from what happened, I feel it was completely justified. It doesn't bother me at all, the fact that we gave the haloperidol. I think what needs to be highlighted more from this case, from my point of view, is communication between doctors, nurses, TACPs, obviously the management of these kind of conditions going forward, and then perhaps the management of from the ward round point of view. Just communication. They could have I suppose contacted us, or I think Donna just found it difficult when she read the notes, considering what we'd been through that night with him, that it kind of laid blame, but it wasn't that. I suppose things can be misinterpreted, can't they?
Yeah, it's not necessarily laying blame. It's you are asked to give a diagnosis, I guess, for what's happened, and so it might just be saying that kind of the drowsiness might be partly contributed by medication. That's not necessarily laying blame, I don't think, but it does show the complexities of this.
Yeah, I think forward
because,
we'd just be obviously more just as long communication, managing the from the nurse as a point of view as well, just education in what certain medications are for, and I think because they start getting, I've found personally, they start be a little bit agitated, so they don't approach them as much, but then they're missing medications that are prescribed regular to stop or help with the agitation, and then it kind of is a snowball effect from there.
Yeah, and I think one of the things that's very obvious from this case is it happened on the patient was a medical outlier in a ward that's just not used to managing this kind of thing.
Yeah.
And unfortunately, I imagine, that's just one of the things that happens with outlier patients when people don't know what something's being given for, or it's not handed over to them what it's being given for, so they just think, oh, it's another drug they normally take, or they're not even used to lorazepam, which is relatively unusual, but I'm sure it happens on places that don't give it. Yeah, and I imagine this is also one of the things that you guys probably see relatively often when you go back to have a look at cases. Because one of the things we're awful at in medicine is kind of criticism of whoever kind of came before us. ED referred to us, and so we love saying how bad ED are at their job, because it's obviously whatever it is that has come out in 12 hours time, because, well, it's obvious in 12 hours time what something is. And they'd have said the same thing if they had 12 hours more, but they didn't. And that's unfortunately probably one of the things I imagine you have relatively often, because 12 hours have passed and results are back that you didn't have. Something like that. Yeah.
Very true.
Medicine is sometimes very messy. In this case, literally so, with what the patient is doing. And decisions are made at the time for good reasons, and I think you've justified what you did and why you did it, and I think that's all we have to really ask for in medicine, with kind of giving things or not. In the previous case, Helen didn't want to give a medication. The on-call registrar did. There's a reason for giving it. Just because I might do something different and I might suggest that I'd go down Helen's route doesn't mean it's right or wrong. It's just a decision that someone made with some information that can be expected. And that's it really, and I think that's exactly what you've done here.
Thank you for that.
Thank you. Right, so meant to be finishing we had. Time if anyone has some simpler questions rather than a complex case or anything like that on either the kind of stuff that I said at the start, the kind of diagnosis, assessment, management, or anything that they've experienced themselves. In which case, just in the chat. What's the best sedation to give out of so I generally give lorazepam because it's simple, but other people give haloperidol. I just kind of think lorazepam has one side effect, which is drowsiness and breathing problems. Mostly drowsiness, breathing problems only later on. And if you're using a little bit, that's not a side effect I'm that concerned about. They're agitated. Well, a little bit of lorazepam. If I'm using a lot, I then get concerned about having a get out, because the only get out to lorazepam overdose is critical care. So a little bit, I often kind of benzos I'm quite happy with. If you're starting to get into a lot, I start thinking, what happens if I oversedate them? And by oversedate, I don't mean just make them a little bit sleepy. I mean kind of respiratory distress. Can I reverse it? Is there any issues with kind of reversing benzos? And often there is with kind of seizure issues. Or is this just someone that if I give too much, they go to critical care? It's why really alcohol withdrawal, I just don't see as a problem. A 50-year-old who's withdrawing from alcohol, give more benzos, give more benzos, give more benzos. Oh dear, I've given too many benzos. They're tired, they're sleepy, they've got breathing problems, well, they need to go to critical care. But if I didn't give them enough benzos, then they're just crazy, because that's what happens. So I really am quite aggressive with benzos and alcohol withdrawal, because there's an easy out for the patients. And as long as you're literally just not giving it every 10 minutes, as long as you're giving something and giving something an hour later and an hour later and an hour later, you kind of run into more problems by not giving it than you do with giving it. And generally, I think you see gastroenterologists have similar kind of approaches. Their patients are undermanaged with benzos rather than overmanaged. It's very weird, very rarely do you get someone overmanaged. And if you're giving enough that you're getting worried about it, there's always critical care. I know it doesn't quite fully answer your question. Haloperidol, ideally you want the kind of ECG beforehand, and to check there's no Lewy body Parkinson's issues. But I don't think you have to have those, especially if you're giving just a little bit. If you're just giving 0.5 milligram, it's more to kind of just deal with, I don't know, it does not very much, I think, in that dose. If you're giving kind of 1, 2, not more, generally not more, maybe you start wanting it, but I don't think it's essential. So that's personal preference. Rachel says, I was wondering whether you'd give haloperidol if a patient was on regular lorazepam. I don't know, or just more. They're on lorazepam, it's not causing any problems. Sometimes a combination of drugs works better than just one, so a little bit of 2 is just as good, or sometimes just they've not got enough of the one that they're on. People that are on long-term kind of benzos are resistant to them, so maybe a little bit more. Kind of had someone the other week who was delirious because of benzo withdrawal, so more benzos worked quite nicely for that one. But yeah, I've done both. So if they're agitated and awake, just more of both. It's interesting, the kind of critical care haloperidol, but that's probably something about a specific cause kind of causing the delirium. You kind of post-critical care or critical care delirium, your post-operative delirium, where I would probably use benzos as well. But I kind of think that's getting a little bit specialist, and you just need to kind of not be clever and specialist. You need to just get through 6 hours or so. And I just don't think it matters that much, to be honest. So yeah, although I keep saying I'd probably use lorazepam, it probably turns out I actually kind of don't with my own patients. So if it's someone else's patients, I'd probably give lorazepam. If it's mine, I might not. I might give antipsychotics. But there we go. Probably if I give it to other people's patients, my general preference is benzos. But yeah, just pick something. Just don't give haloperidol to your Parkinson's patients, please. That's all really. Helen.
Yeah, thank you. Thanks very much. Thank you for everybody for coming, and for our colleagues at Barnsley, and I think we've had a few from Doncaster as well actually tonight. So yeah, it's been great to all get together. Thank you again for your time, Matthew, and yeah, I guess we'll see you all next time. I'm going to pop a link in the chat to a survey. There's me and a few colleagues from the region working on trying to formalise this platform and to make it better for everyone, and to try and understand what people want and when they want it. So I'd be really grateful if you could complete that or send it on to your teams. And that's it. Thanks very much.
Thank you.